So you guys will have to tell me what you're thinking, or I'll see if I can pull up the chat box, but chat it in or speak up. Okay, Anu says IVC lesion, excellent. So we can see that there is this T2 hyperintense lesion in the IVC. It's displacing this flow void over here. And we've got several guesses for IVC leiomyosarcoma. And didn't show you the whole thing, but there's also something over here. So we've got leiomyomatosis, and somebody's asking about the adrenal gland. Good. So this is the arterial phase. We can see that there is enhancement of the lesion, and also, so the kidney is normal, and then there is an adrenal mass that is like connected through the adrenal vein to the IVC that is enhancing and washing out. Excellent. So we've got adrenal cortical carcinoma with invasion into the IVC. We also have a guess for a pheochromocytoma or ACC. Exactly. So this is our typical like mid-large adrenal mass growing into the IVC. So this was an adrenal cortical carcinoma. The differential for a mass of this size, especially enhancing and washing out, would definitely include a pheo. I would say I lean sometimes more towards adrenal cortical carcinoma, especially when it's invading the IVC, because it has a higher rate of invasion. And then also if it has more central necrosis. In this case, it just enhanced and washed out. So it didn't necessarily have central necrosis or hemorrhage, but it did have, and it also wasn't very, very T2 bright. So that would be the other thing that would have been more suggestive of a pheochromocytoma. So this was just an adrenal cortical carcinoma. So ACC is the abbreviation, but 40% of these are hyperfunctioning, and that's more common in women. And they'll present with excess cortisol, so they'll present with Cushing syndrome. They can also get virilization or feminization due to androgen release. The typical imaging features are they can be very, very large. The average size is over 10 centimeters. And this central areas of hemorrhage and necrosis, and about 30% of them have calcification. So that is also a clue more towards adrenal cortical carcinoma than a pheochromocytoma. And then 40% of them also have venous invasion. So they'll either go just a little bit into the adrenal vein or straight up into the IVC. So this, that would also be a clue for an ACC over a pheo. So the differential would include a pheo, metastases, and adrenal adenomas. Adenomas don't usually get this big. Pheos can be mid to large size. They tend to be T2 bright, enhance and wash out, but they can look like basically anything. So if pheo is still in the differential, you can correlate with metanephrines, consider doing either an MIBG or a dotatate scan. And then the interesting thing about this case, the one that I just showed you, was that it was actually growing up into the suprarenal IVC. So you can see it growing up here and then almost into the right atrium. So it's in that like little area of the IVC above the liver and into the right atrium. So there is a criteria for how they grade these tumor thrombi. So if it's below the hepatic vein confluence, so say the adrenal gland is just going into the IVC, that's the best case scenario because they can just clamp off the IVC and resect it. Even if they have to resect part of the IVC, that's much, much easier than having to deal with the hepatic venous confluence, which could potentially compromise the liver. If there was an infradiaphragmatic thrombus, so it's still below the diaphragm, but it could be extending to the level of the hepatic veins, they'll usually do what they call the hepatic vein exclusion, which means that they'll clamp off the IVC up here. This is actually pretty dangerous. They cause the patient to get immediately hemodynamically unstable and also obstruct the outflow of the liver, which can be very, very traumatic. But they'll try to do this either like continuously or intermittently. And then they'll try to go up and resect the tumor from below, peeling it out of the IVC. Hopefully it's not invading the wall of the IVC. and then they're able to preserve the hepatic vein IVC confluence. And then if it's diaphragmatic, which is the case in my case, or if it's going into the right atrium, they actually have to put the patient into cardiopulmonary bypass and circulatory arrest. So they will they'll put the patient on bypass, open up the heart, open up the right atrium, and then actually resect the tumor from above so that they can remove as much of it from above in the right atrium and the upper IVC as possible. Then they'll clamp the IVC from below and then pull the tumor out from below. The reason they want to do this is because it's extremely difficult to reconstruct this hepatic vein IVC confluence. So for example, you can see here the hepatic veins are coming in. And actually in this case, there was even a little bit of a thrombus in the right hepatic vein here. And so you can see that if this was actually invading the wall of the vein here, that'd be very difficult to resect and to reconstruct. And I was asking my surgeon, what would you do if it was actually invading the wall, like it didn't just peel out? And he said at that point, they would actually have to contact a transplant surgeon, take the entire liver out of the patient and reconstruct the hepatic vein to an IVC graft outside and then bring it back in. So much, much more difficult surgery. But he said, luckily, most of the time when you have an adrenocortical carcinoma that invades the IVC, if you do have invasion of the wall of the vein, such as the adrenal vein or the IVC, it's usually kind of on the lower part. And by the time it comes up here, it's usually just an intraluminal tumor thrombus that's not actually invading the wall. So I thought that was really interesting. They had to put this patient on bypass, go through the heart, debulk or resect the upper part of the tumor so that they could pull it out from below and preserve this hepatic vein IVC confluence. And Steve is saying similar issues arise for RCCs. Exactly. So same exact thing. In RCCs, and actually one of the other things that one of my urologists often asks me is if I can tell that if it's invading the wall of the IVC. And I always tell them, like, I just literally have no idea if it's invading the wall here. If there is a little bit of separation, sometimes you can use ultrasound to do that, but it's very, very difficult. So, but it is helpful for me to now know that, most of the time, if it is invading the wall, like on the PAT specimen, this was invading the wall of the IVC, but lower down. So they basically resected this part of the IVC, but they were able to preserve the confluence here. And then Steve also said, the bigger it is, the more likely it invades. Yep. Yeah, so this one was pretty fat. So, I mean, it's pretty lucky. We also have had some RCC cases that were invading the IVC that they went, when they went to go clamp it, part of the thrombus embolized. And so that creates the problem where now you've got, tumor embolizing through the heart out into the pulmonary arteries. And sometimes they've actually gone in and fetched it out of the right atrium or out of one of the pulmonary arteries. So that's another potential thing, is embolization of these tumor thrombi. Oops, stop sharing.